When the COVID-19 pandemic started raging, there was a lot of concern about using CAR T cells. It's a very high-risk therapy. While it can be administered inpatient or as an outpatient, it requires a lot of intensive follow-up. That means there's a lot of exposure of staff to patients and a lot of exposure of patients to many different people in the medical setting, from nurses, technicians, phlebotomists, physicians, a lot of back and forth in and out of the office. And there was a lot of concern that we had to limit patient exposure. In addition, there's a lot of concern about resource utilization. At the height of the pandemic, hospital beds were limited. Perhaps up to 25% of patients who get CAR T cells may need ICU level care, and certainly ICU beds and ventilators were a very limited resource. And so there was a lot of discussion about limiting CAR T cells because of exposure to patients, because of exposure to staff. A lot of people were working from home, but also because of the limited resources, both in the outpatient setting, but certainly in the inpatient setting. Even those patients who would get CAR T cells as an outpatient may need to be admitted and may need inpatient services as well as ICU level services, ventilator care, et cetera. That said, many of the patients who are appropriate for CAR T cells, at least in the current environment, are patients who have incurable diseases. These are patients who have largely exhausted most conventional treatment options. And CAR T cells really have been thought of as a life-saving therapy. So we had many discussions with my group at the University of Pennsylvania, but also with many of my colleagues in the community. And I think the general consensus, and in fact we had published what we felt the consensus should be, is that CAR T cells should be thought of as a life-saving therapy. That patients who were appropriate for CAR T cells, who would be put at increased risk by delaying therapy, should still be able to get CAR T cells on schedule. Of course, the use of CAR T cells has to be judicious, even in normal circumstances, but certainly in the setting of the COVID-19 pandemic. Patients who were stable, who could wait, who were not as emergent, really could safely be delayed, and that is okay. But I certainly don't feel that patients who have a limited window of opportunity to receive a potentially life-saving therapy should delay CAR T cells. Of course, this depends on the local environment. If there was a setting when, in fact, there were no hospital beds and there were no potential ventilators, patients should be delayed. We shouldn't be giving CAR T cells if we didn't have the ability to manage them and care for them afterwards. But I think in the majority of circumstances, what we learned is that by applying these to the most appropriate patients, we could provide potentially life-saving therapy when it was needed. And therefore, while we needed to be very thoughtful and judicious, CAR T-cell therapy really has gone on even during and through the pandemic.